I'm Aubrey Shick, and I'm a new research affiliate at the Atlas Institute at CU Boulder. Since about 2013, I've been deploying socially assistive agents with children and older adults with memory care needs. So the children have been primarily autism spectrum, and the older adults have been dementia and Alzheimer's patients. So at this point, it's actually been thousands of individuals that have interacted with these systems. So a socially assistive agent, as opposed to, robots or agents that help us with physical tasks or things like that, it's closer to a coach or a therapist or a peer-like experience that motivates and engages the individuals. And since beginning to deploy these systems in my research at Carnegie Mellon in 2013, I've spent a lot of time in industry, and I've actually just recently returned to academia. And I'm really, really passionate about the opportunities in digital health and digital therapeutics. Many people don't know that while they're familiar with the FDA's medical device track and the clinical trials and whatnot related to that, there's a new track within the FDA that's only existed for about 3 years called digital health that includes software related solutions. So where this project is now is we have an open source software that allows for both in-person interventions where therapeutic interventions can be crafted by a therapist or a child development specialist or a teacher that then can be, implemented with the children where either robots or, app-based agents can interact with the children. What we find, the biggest report that we find from teachers and parents is increases in self-esteem. We see dramatically lengthened engagement, increases in verbalization. This also this also applies to the memory care patients as well. So I've worked with a large nonprofit in Pittsburgh that sees about 200, pre-COVID, about 200 children in regular weekly classes and about 400 older adults with dementia and Alzheimer's in other programs. So this is a hardware agnostic system. So we're trying to take an asset-based approach. So if you have a mobile device or you happen to have a computer or you have VR, a clinician that is creating content or interventions is able to leverage any of those systems to be able to implement these therapies. And so what I'm really, really looking for is research clinicians, folks to help with clinical design, behavioral psychologists, neuroscientists. I've had amazing experiences working with occupational therapists, BCBAs, speech and language pathologists, and again, across the different ages. We currently have funding from the National Science Foundation, or the Autism Science Foundation, that is allowing us to adapt and scale the existing software to serve more individuals. But we're very, very much looking to have more clinical validation to take some of the really, really exciting anecdotal evidence that we've seen and really, really drive that toward that digital health application and scaling that opportunity. Because what this really allows for is that a clinician can create an intervention that then can be either implemented at home or implemented by a less technical or a lower skilled, maybe registered behavioral therapist or otherwise behavioral specialist to work with these individuals. And also the systems, the data from these systems can be built upon and learned upon so that we can have greater and greater levels of automation. But just to be clear, and it's kind of hard to see in the little tiny diagrams, but we're not advocating to have patients interact solely with robots or solely with technical systems. This is a bridge to generalized engagement with humans, and that's been one of the biggest reports that we've gotten from folks who've been using this in the field for years. And I'm not sure, is my little timer up or not?
Just about.
Okay, I don't see it. Oh, there we go.
Thank you. I know next we have Peter.
Good morning, everyone. So the work I'm going to talk about is applying an approach to computational speech and language analytics. And the goal really is to distinguish frontotemporal dementia from primary psychiatric disorders. And I'm in the Institute of Cognitive Science. I'm also collaborating with this with Dr. Peter Pressman, who's in neurology at Anschutz. There's been a real problem in that people who have frontotemporal dementia, it's very hard to distinguish this from primary psychiatric disorders, and that can include depressive disorder, bipolar disorder, schizophrenia. And over the last 10 to 15 years, we've been working on sets of technology where we can analyze people's language, so spoken language, what they say, how they say it. And we've developed some techniques that are very sensitive to detect how severe their mental illness is, the types of mental illness they have, just by pulling out various different features from the language. So in this project, what we're proposing to do is to apply some of these kinds of speech analytics to distinguish these two types of disorders from each other, and use that first to be able to provide some useful tools that can help clinicians, because right now the only way the clinicians can really do it is through sort of large batteries of interviews. And second, also to use this as the basis to understand some of the more theoretical and mechanistic relationships between language measures and neuropsychological and linguistic features that are happening in people's brains as they're doing it. So our approach to this really is we collect recordings of people speaking. We've developed a number of different types of tasks to do that. We apply a set of analyses to assess the language that they're saying. Then we provide machine learning and do classification on this. So our approach for this really is, the first stage of this, we're going to use some existing pilot data that has been collected. We're going to analyze these and then try to build a system that can really distinguish the PPD from the FTD people there and look at how that relates to it. The longer term goal of this work is to be able to do this longitudinally, where we can track people over time and look for small changes in their language that are indicators or biomarkers of changes in their mental states over a period of time. The team that we have for this is myself at the Institute of Cognitive Science in Boulder, Dr. Pressman in neurology, and in computer science, Jim Martin, and one of my graduate students, Chelsea Chandler. We're looking for additional expertise, particularly people in psychiatry, as well as people in computational bioscience. And this is a new project, or at least this group we're pulling together is a new group. We've been funded in the past from NIH and from the government of Norway for doing a lot of this work. But where we see this going is new kinds of tools that can use speech-based technologies, particularly in this case to be able to distinguish PPD from neurocognitive disorders, which is a big bottleneck in the clinical field. But we also see this as really improving our understanding of a lot of the underlying features in speech and how those relate to the brain's neurocognitive and linguistic mechanisms. And that's it. Thank you.
Thanks very much. Next we have Jacob Holzman.
Awesome. Hi, I'm Jacob Holzman. I'm an assistant professor here at the University of Colorado Anschutz School of Medicine. I'm in the Department of Psychiatry. I'm developing this proposal along with my co-investigator, Dr. Sue Rhee, whose primary appointments are in the Institute for Behavioral Genetics and the Department of Psychology and Neuroscience at UC Boulder. We found our collaboration because our interests align in understanding mechanisms that are underlying development and maintenance of youth mental health concerns, particularly for those at risk for later conduct, aggression, or delinquency issues. We're both interested in examining whether or not those underlying mechanisms might translate and inform our development and adaptation of interventions that address youth mental health concerns. What we know from a lot of basic and longitudinal research is that there's a common set of risk factors for those later conduct concerns, and that's particularly how children regulate themselves, parents regulate themselves, and how they also do that together during interactions. And so that has informed a lot of our interventions. So our clinic at Anschutz, where I provide a lot of services and do research evaluating factors that are involved in the efficacy of those interventions, we're working on examining how we might be working to change parenting practices and use parenting-focused interventions during early childhood to act as preventative interventions and ways that we might ultimately make them more efficacious at reducing risk for later conduct concerns. Our work in these parenting-focused interventions, is originally developed just to focus on changing parenting practices. So specifically, we work to reduce harsh parenting, so things like reducing yelling at children, doing less criticism of children, or doing less things that might be falling into categories of corporal punishment, like spanking or slapping children. Alternatively, we also work to increase how parents might spend more positive time with their children, find ways to praise children, and ultimately use the shifts in parenting to change how we might regulate ourselves during interactions. One of the biggest challenges in these interventions, though, is that not all children and parents actually respond, and so we don't see as much change with them as we might hope to see, and which is where we think that work done by Dr. Reid and her team is really important. Their work primarily examines genetic, neurobiological, and environmental mechanisms that underlie how we develop our ability to regulate ourselves, specifically developing self-regulation for our thoughts, our actions, and also our emotions. And so the Boulder team has a lot of expertise in how we can actually measure self-regulation. They use a lot of neuroimaging, objective neuropsychological testing, and even report-based of executive functioning. And so we want to capitalize on their expertise in that measurement and start to integrate that in our technical approach by using that within our interventions to see whether or not it predicts responses. One of the things that really connects is that they've spread a line of research showing how parents' ability to regulate themselves is linked to parenting behaviors, which is what is thought of as our mechanism for these interventions. And so what we look back to is that they don't actually have a design in mind for parent self-regulation in the beginning. And so we have this question of whether or not that might predict responses at the end. So we plan to utilize our combined expertise in providing the interventions and evaluating the efficacy, as well as how we measure self-regulation. This is a brand new project, and we're hoping for developing pilot study here to look for future funding at the NIMH level for K awards or an R21 mechanism. Ultimately, we hope that this can increase collaboration between our departments and the interdisciplinary collaboration across different types of ways of measuring self-regulation, and then ultimately try to change our interventions to adapt them to be more helpful for parents and youth struggling with mental health concerns.
Thank you. Next we have Colleen Reid.
Hi everyone, I'm Colleen Reid. I'm an assistant professor in the geography department at CU Boulder. I do health geography and I also have training in public health. So I'm on the Boulder campus, but much more of my work is possibly thought of what you find at the School of Public Health on the Anschutz campus. And I have two main lines of research. I'm going to focus on one of them today, which is looking at wildfires, and partially because I think that's on everyone's minds with the air quality we've been experiencing for the past couple of weeks here in Colorado, as well as the intense wildfires in California. And so I think, you know, my intent on being here was to find collaborators. I have a lot of different ways I want to go forward with my wildfire research, and I was hoping to find collaborators interested in that from the environmental side. My network seems much more biomedical here, but my work has been to look at the health impacts of wildfires. And I think there's a few different ways that I could go in the next steps. There's a lot of open questions that need to be addressed that I'm asked a lot by the public. So for example, what interventions from the public health side could decrease the health burden as we face these extreme air pollution events? Understanding why people do or do not adopt certain public health interventions. There's also an interest in what the long-term health impacts are. Most of our understanding to date is about short-term acute impacts of the air pollution, as well as combined exposures. For example, right now we have extreme heat and air pollution, as well as the COVID-19 epidemic. So what I tend to do, and in the past, is I have a lot of expertise in estimating air pollution exposures using machine learning and geostatistical methods. And then I link that with health data to try and find associations. I think depending on what question a group of us were to go forward on would determine what my collaborators need to be. I have worked with people from the Forest Service, NASA. I currently am trying to collaborate more with researchers at National Jewish and Colorado State, but would like to have more researchers within the University of Colorado. And I've also been working with researchers at NCAR. So potentially there could be a need for people on the engineering side in terms of indoor air pollution, efforts to try and decrease indoor air pollution and its impacts on health. I always need statisticians to work with to think of new methodologies to get more at causal inference. I've worked previously with MDs, so pulmonologists or other people who can really get at some of the biomedical aspects of things. If we were to look at, why are people adopting certain techniques but not others, we could look at, I think sociologists or psychologists could be helpful in that. In terms of funding, I've had trouble with this. I've been funded by the EPA before. They aren't funding as much external research, but they're really at this intersection of health and environment, which I've for other places. So I've been funded by the Joint Fire Science Program, NIH, and NASA, and I've recently submitted to the Health Effects Institute. So I'm open to talking more about that. And really, we're not going to get rid of wildfires in the Western US, but we still have these health burdens associated with it. So I want to shift my research more towards understanding how we can decrease the health burden, despite the fact that we are going to continue to see these smoke events. And I think that's all I've got for today.